Please welcome Dr. Darrell Wheeler.
Rudy, you were a bit quick. Good thing I didn't go and take a biology break. Those of you who know me, you know I'm a very shy and quiet and reserved person. Thank you for not acknowledging that. Good afternoon, everybody. It is indeed a pleasure to have the opportunity to join with my colleagues who are local and both national in doing a presentation to this austere body. During the earlier sessions, I had the benefit of learning from the presenters and also learning what I needed to take out of my slides. So I morphed my presentation a bit and realized that what I wanted to do from my heart actually was to talk about this journey. And I know we are going to have a panel a little bit later, but rather than to inundate you with my own historical slides, and as Dr. Wyatt pointed out, there are things that you can get, articles and things that are readily available. I'd like to take this opportunity to talk to you about this journey, and in the room right now, I would say I'm probably one of the oldest out Black gay men who have with a doctorate degree doing HIV work, certainly one of, and I mean both in terms of years and in terms of time doing this work. And it has been a journey, because when I started doing this work, there was no room like this. There was nobody out there in this space who said, we have a Black gay research group for you. We have a network of non-white scholars who are going to work with you. We have a network of gay men and or women who are really introducing new people into this work. And so there was a lot of youthful fumbling, mistakes, mishaps, and redirections that occurred in this journey. And they led me to think about HIV prevention work, I'm sure, the way that I do. As was pointed out, we are the amalgama of everything that came before us in our lives. And there's nothing about me today as a Black gay man speaking before you that is not anchored in something that happened to me yesterday. And I'm very clear about that. And so one of the things I'd like to begin with is a brief story. And this is a story that is really helping you to see how I might see the world of HIV and AIDS for Black men. Envision a stairway with, 20 or 30 steps on it. And you're on the stairway about to come down. You're dressed in, we heard from the house ball community earlier, and you're going to walk a category. So you're dressed, all right? You're ready to go. And as you take that first step, you turn around and see me standing behind you. Then you turn to walk down the stairs, and you feel a sharp push in your back, and you fall down those stairs. Now, you can't say for sure that I did it because you're looking forward. But you know you fell, and you know you felt a sharp push in your back. A month later, you're going to walk again, and you're dressed in your finery. And you turn around, and there I am standing behind you, and you go to walk down the steps, and you feel a sharp push in your back, and you fall down the stairs again. Imagine a month after that. You're about to walk in your finery again, and you turn around and see my ass standing there. What are you going to do? You're not going to step forward, correct? It is not an illogical fallacy for you to quit redirecting the blame on the victim of the oppression and start to look at the oppressor, even if you're not confirming that the oppressor is the one doing that action. And so as I start to think about research with and for Black men, I really started to question the paradigms in the 80s that were putting fault and blame on the Black men themselves, and recognizing that one cannot understand an oppressed individual without understanding the forces of oppression. So as Greg pointed out earlier, I took a very early interest, both personally, being a kid from the south side of Chicago, having grown up in the late 60s and been, beaten up as I crossed Marquette Park and other places. If you know Chicago, that there were environments that Black folks just didn't go to more than once by groups of irate, irrational white kids who just thought I shouldn't be there. It is the product. I am the product of that environment, and recognizing that I had to see the world a different way because of the journey I took. And so I tell you that story because I want to contextualize that mine is an experience in this equation and not the only voice in this equation. So when we think about the kinds of things that I'd like to accomplish today, I want to contextualize through my own personal narrative a perspective on HIV prevention for and with Black and African American men who have sex with men and women in the United States. And I would call your attention to the difference in the lexicon being research with, research on, research for, and research as a collaborator with and a member of the Black community. They are not all the same. Many people are doing research on Black MSM. Many people have done research with Black MSM. But as we've heard from Rudy and others, it is so intimately integral to the work that we do that you have a cultural nuance of understanding of what you do, that we must have men from the community who understand the community from a lived experience contributing back to this agenda. This in no way negates anyone else's contribution. And if you hear that as my thesis, then you're not hearing what I'm saying. What I am saying, it is crucial for us to have men from the community contributing to the research. It is not the only voice that should be at the table in the research equation. I'd like to raise concerns and challenges that arise from my perspectives on this agenda, both some of my own challenges and challenges that I've encountered along the way, and I'd like to cite my own research in doing that and that of other contributors. And I absolutely would like to celebrate the possibilities of what can be a result of the collective work, including this gathering. If we're not seeing the possibility for a celebratory moment, an opportunity to grasp the resources and to move forward, we shouldn't be here. If we're going to conclude the day with, oh, another study needs to be done, another paper needs to be done, as opposed to saying we are going to raise the ranks of individuals who have the capacity, the knowledge, the will, and the resources and the hand back to do this work, we've wasted our time. In the earlier years of this epidemic, we heard language like state of emergency in Black communities. How many people remember that? Well, if there's been a state of emergency, how come we haven't acted like that? We can't continue to chip away at the iceberg with a toothpick the same way we've been doing in this, the third decade of the epidemic. It is no longer feasible, it is no longer acceptable, and I know for one, I'm really tired of hearing some of the same stories at the conclusion of the day. So why are we having this discussion? You know, this is one of those slides I decided to just take out the data because we saw the data. Greg Millett and others really reinforced in quite elegant ways why we're doing this work that we're doing. The epidemiologic studies that we don't need another one to prove show that Black and African Americans and MSMs are disproportionately represented in the HIV statistics. We know that. You don't need me to tell you, but that's one of the reasons we're here. There are disparate rates of testing among African American men. Even though we saw from the data that men are getting tested, the jury is still out on what is adequate testing. Because just because you get tested once doesn't mean that you shouldn't be tested very frequently based on your own experience of your activities. And again, Dr. Wyatt is very clear about that and others about you have to contextualize the understanding of what you're doing sexually in your lived experience, not my experience. And so I don't come as an expert on anything that anyone else is doing in this room, and that's why I titled my story, My Journey and a Perspective. We understand that as individuals enter this epidemic, African American and MSM, their stage of disease progression looks very different than other groups. And if that stage of disease progression looks different, it is not necessarily just the fault of the individual, but we must question the circumstances, the sharp push in the back that one feels, and the links that one makes between that push in the back and the actual source of that push in the back. And there is a belief that there are things we can and should do to ameliorate these conditions is truly the take-home for today's discussion. I'm one of these people who, when I was single, I made a horrible date because I like to know the end of the book, the end of the movie, how the story is going to end. You could not take, I mean, I don't want to go if I don't know how it's going to end, because I don't want to sit there and waste my time and not like it. So I really want to know what's going to happen. So I'm going to begin my presentation by telling you how I'm going to end my presentation. So I'd like to get to the closing remarks. Provider systems will absolutely need to increase their understanding and advocate for interventions that target basic human needs. As a social work practitioner, Charlotte Towle and others in the historical writing took us right there. Basic human needs. You know it's Maslowian. If you don't have the foundation taken care of, how can you go to those higher order things? Issues of housing, issues of income, issues of education, and the criminal justice system, and those are so intimately intertwined, must become part of the paradigm. These are not push-aside agendas. And if, as we heard earlier, the behavioral interventions are not sufficient in and of themselves, we have to look at other contextual factors. And I would argue and posit, certainly through my research and the research of many men and women in the room, that it is supported that housing, income, and education must be addressed. There is a need for a deeper examination of the factors which impact the lives of Black MSM, issues of social isolation. And social isolation is not necessarily a product of people wanting to be alone or just being secretive. Let me be very honest that as a Black researcher with 2 master's degrees, a Ph.D., a pre-doc, a postdoc on several faculties, I live in isolation. I live in isolation in many important and intimate ways. There are times I feel that there are tests of authenticity that come my way which don't allow me to be the whole person when and where I choose to be. Because at times, even if it's a construct in my own mind, I'm worried about what my actions will convey to the men and women who watch me and may come behind me, and I'm certainly watching the way things will impact individuals who will be judging me and judging the work that I do. I live in isolation. So we're not just talking about economically disadvantaged folks living in central LA or in Harlem. There are negative life experiences, including sexual abuse. And I'm glad somebody asked the question about the parallel structures for childhood sexual violence and others. Having been a co-principal investigator on Brothers y Hermanos, which was the first CDC study specifically looking at epidemiologic study looking specifically at Black and African American men, no less than 30% of the men responded that they had experienced childhood sexual violence or interpartner violence, no less than 30%. And so we're talking a significant epidemic among men who have sex with men as well as heterosexual individuals. This is not an isolated experience. So we have to understand the lived experience. And as was pointed out, this is what men revealed to us. It wasn't just bringing men into the study who had the experience, but it was asking men in a meaningful way and asking them to contextualize their lives, and they reveal it. Also, when we saw some data earlier and we start to talk about, well, why do we see rates go up? Come on, we are a people of relationship. I tell you, and researchers fall into, and we'll talk about this a little bit later, researchers fall into this very comfortable sphere that we believe everything that our subjects tell us. And that's because we want to believe it because it's good for the publications. Let's be honest, nobody tells you the truth the first time they come in. They tell you what you want to hear, and especially in research-savvy environments. New York being one of those, men will tell you anything they need to get into the study, and especially if there's an incentive attached to it. All right? And you should not fool yourself as to think you are discovering Jack. You are recovering the reality that they're willing to give you at that moment in time. You are recovering the reality. You haven't discovered anything. Be mindful. All research is yesterday's news. All research is yesterday's news. We don't have a crystal ball. We predict on models going forward, but our research is based on information that we can collect, which means it's what has already transpired. So everything we do as researchers, in its best and most optimistic, is about the probability and the likelihood of what can happen tomorrow. It is not a guarantee of what happens tomorrow.